welcome to Preemie Chats, a place for parents and healthcare professionals to gather, share stories, and learn from each other. I'm your host today, Jenna Morton. I am the mom to 32 weekers who are now 10 years old. Preemie Chats is a creation of the Canadian Premature Babies Foundation, also known as CPBF. The foundation is a parent-led charity that helps families during and after their NICU journey through education, support, and advocacy. Please take some time to visit our website. You can see it there on the screen, canadianpreemies.org. You will find all kinds of resources on the site, as well as all of our past Preemie Chat videos, our podcast episodes, and most importantly, you will find a community of parents and professionals who are working together to help our children thrive. Our comment section is open. We'd love to know where you're watching from, and we hope that you'll feel comfortable to join in the conversation today. You can post questions in the comments and share your thoughts as we go through the presentation. And speaking of questions, a question that always is on the mind of preemie parents is, why did this happen, and could it happen again? And while the research reveals many risk factors for preterm birth, the cause for most cases is never determined. And understanding that why will improve our efforts to prevent premature birth. Today's discussion will highlight some of the research that's happening in this area with Dr. Giulia Muraca. She's a perinatal epidemiologist and assistant professor in the departments of obstetrics and gynecology and health research methods, evidence, and impact at McMaster University. She leads a research group that specializes in linking and analyzing large data sets to study maternal, fetal, and neonatal health and health services. Today, she's going to share some information with us about the links between modes of delivery at birth and how they may impact preterm birth. Welcome to Preemie Chats.
Oh my goodness, this is so exciting. Thank you so much for having me. I don't think I've given several talks, many over the last, 2 weeks, when of course I'm recovering from COVID and still have that lingering cough that half of the population has right now. But it's so incredibly exciting to be able to speak to this kind of audience, and I'm so grateful for the invitation. Thank you.
Oh, thank you. I know that this is going to be a lot of information, but a lot of really useful information, and information that I know, as a preemie mom, you always kind of have these questions of like, is there anything I could have done? Is there anything that we know? And as you start to look into it, there hasn't been a whole lot of research in this area, but more and more is happening. And having someone like you to kind of walk us through what that research is and what questions we should be asking, I think is going to be really fantastic.
Yes, and that's exactly how I hope we go through, kind of like I've tried to structure some, the conversation, and also I hope that's how we can pursue our question and discussion period, because that's exactly what I'm meant to do. That's exactly what my purpose is in this space, is to figure out, try to help to navigate the numbers and the interpretation of some of these things, especially in subjects like the cause of spontaneous preterm birth, which is so incredibly mysterious. Mm-hmm. Shall I launch into my slides, Jenna?
Sure, that would be great. I'll bring them up on the screen for you, and I'll let you take it away.
Okay. So the first thing I want to mention is that I have no conflict of interest to declare. That being said, we all come to every subject with our lived experience, and we all have our own personal biases, and we all have our own experiences that we think about when we hear words like cesarean delivery or preterm delivery or morbidity, and I come with those as well. I don't have a clinical practice. I'm an epidemiologist, so my patients are the population that I'm studying, looking at numbers. So remember, that's my bias, is that I'm constantly looking at a population level kind of patient. And so that's the bias that I bring to my work, although I'll be clear, I have absolutely no commercial bias. And so I'm sure there's a lot of this that I don't have to mention to this crowd, but I think that we should never forget the fact that preterm birth occurs very, very frequently. It occurs in approximately 8% of deliveries in Canada. And that's 29,000 infants born preterm annually. This crowd knows the leading cause of infant death and morbidity throughout the life course. And in Canada, 2/3 of these preterm births are classified as spontaneous preterm births. And so these are distinguished from medically indicated preterm births or clinician-initiated preterm births, which are preterm births that are describing when a clinician initiates or decides that delivery should occur preterm because continuing the pregnancy would actually outweigh the benefits of waiting for labor to begin spontaneously. There's that much threat. We're not talking about that group of preterm births in this on this subject. We're talking about spontaneous preterm births. And I realize, Jenna, we didn't say the name of my talk, or at least I didn't. So let me just back up 2 slides and just make that clear. So today we're going to be talking about mode of delivery in a previous pregnancy, obstetric injury, and preterm birth. And we'll be talking about, we'll be talking about if there's a link. So let me return to my background slide here. Okay. And so we're not talking about those medically indicated or clinician-initiated preterm births in this talk. We're talking about the spontaneous preterm births. And so generally, those are classified in 2 different categories. They include preterm births that follow spontaneous onset of labor, as well as those that follow a preterm pre-labor rupture of membranes, or a PPROM. So again, probably not super new for anyone. It's obviously something that's touched all of our lives, and I know I don't have to convince you, but the impact of preterm birth is obviously substantial and extends far beyond infancy, and is associated with increased morbidity throughout the life course, as well as subsequent adult onset chronic disease. And in addition to all these health effects of preterm birth, we haven't even, the enormous financial impacts and social impacts on affected individuals and their families can very often never be quantified. And so we know there are established risk factors for spontaneous preterm birth, and they include prior spontaneous preterm birth, having a short cervix. They include, having smoking use or drug use during pregnancy, being underweight or obese, having a maternal comorbidity like diabetes or hypertension, being of low socioeconomic status. And there's more recently, we know that spontaneous preterm birth should really be regarded as a syndrome of multiple causes. So it could be infection or inflammation, or what we have termed insufficient cervix, which is an awful way to describe a cervix that cannot hold a pregnancy to term, vascular or placental disorders, and uterine overdistension. These are all a part of this kind of syndrome of spontaneous preterm birth. But despite the significant burden related to preterm birth, the cause of the majority of spontaneous preterm birth remains unknown. And it's really important that we don't just become complacent and say, this is just something that we're never going to get to the bottom of it. I don't believe that. And I think really applying really innovative and developing innovative approaches to understanding and preventing spontaneous preterm birth, even if it's just a little bit of the time, it still is a public health priority. And so when we think about, identifying risk factors, what we're really super interested in is identifying those modifiable risk factors. Some of the risk factors I mentioned previously aren't modifiable, but some of them are. And so identifying these modifiable risk factors that have the potential to prevent spontaneous preterm birth, it remains one of the most critical and elusive goals for reducing infant morbidity and mortality. So what does this have to do with mode of delivery, and what does it have to do with obstetric trauma? So one potential modifiable risk factor for spontaneous preterm birth is cervical injury. in a previous pregnancy. And this has been something that's sort of, I don't want to say it's exploded in the literature over the last 2 years, but there's been quite a lot of buzz about this in my, in the academic and clinical space over the last, I would say, 2 to 3 years. And there's a number of papers that keep being published where people are postulating this relationship. And so before we talk about how that works and what that mechanism might be between, having a cervical injury and having a spontaneous preterm birth, I want to just make sure we're all oriented to the anatomy of the cervix so we can really visualize what we're talking about. So here you can see in this illustration on the left that the cervix is that lower narrow end of the uterus that connects the the uterus to the vagina. And if you look at that middle photograph, that middle illustration that shows you the view of the cervix, so we use the term an os or a cervical os to describe the opening of the cervix, and this happens at each end of the cervix. So each opening of the cervix is called a cervical os. And the tube, the inside of the canal, is called the endocervical canal, and you can see that illustrated in that diagram on the right. And so the external os is that opening that's near the vagina, the opening of the cervix nearest to the vagina. And the internal os is the opening of the cervix that's nearest to the uterus, so at the top of that diagram on the right. Okay, so one potential, so the theory is that injuries to the cervix could compromise the integrity and function of that cervix and lead to this, cervical insufficiency in that subsequent pregnancy. So this is a diagram that's supposed to help visualize cervical insufficiency. So on the left, you see a cervix that is not affected by insufficiency. The cervix is closed and it's rigid until delivery. Then when, in response to contractions, that cervix will then efface and dilate. Excuse me. So in response to contractions, it will efface and dilate. On the right, we see a cervix that shortens or opens too soon during early pregnancy. And this is what causes that preterm labor and the injury that ensues. And so in these last, 24 months especially, but, even there's been some isolated reports even earlier, this evidence has been accumulating to support this increased risk of spontaneous preterm birth among individuals with a previous emergency cesarean delivery compared with people who have a previous vaginal delivery. And actually, this is the title of this paper and this commentary is actually a misnomer because it's not all emergency cesarean deliveries that we're seeing this increased previous emergency cesareans where we're seeing this increased risk. It's actually only those emergency cesarean deliveries that occur in the second stage of labor. And this is a really important distinction. And so I just want to remind everyone what most of us probably only remember what this felt like and didn't really know when it was, how it's defined. But it's really important for this conversation, at least, that we understand what we mean when we talk about the second stage of labor. So the second stage of labor, as you can see on the right side of this diagram, is when it's when a pregnant person is fully dilated at 10 centimeters, and it's often called the pushing stage because this is when pushing usually begins. Okay, and so remember that when we talk about interventions and what might happen in the second stage of labor. So this is another diagram showing you, this is meant to describe or illustrate the uterus. And the top end of that uterus is it's the active part of the uterus. The middle part is the passive part. And at the bottom here, you can see that the cervix is there in the bottom right of these diagrams, and the internal and external cervical os are indicated. Now, as we go from left to right in this diagram, we're showing the changing positions of those cervical os as labor progresses. So you can see that internal cervical os and that external cervical os are sort of pulled up to become part of the lower segment of the uterus. Okay, and I'll show you another diagram that kind of depicts this in a cool way. So here again, we're seeing from left to right, essentially on the left, we're seeing a non-pregnant uterus, and on the right, we're seeing a uterus in the second stage. So in that, you're fully dilated and you're in that pushing stage. And so what you see is, again, the muscular fibers at the level of that os. In this diagram, the EO is showing you external os, and the IO is showing you the internal os. And you can see, again, in that second stage of labor, that those, that cervical os is pulled upwards. And it's actually the description of it in textbooks about this process is that it's taken up into that lower uterine segment and it almost becomes continuous and thinned. So it's hard to distinguish between the lower segment of the uterus and the upper segment of the cervix. And so here we see this diagram below the cross sections of the uterus, where we see, where this is the most common incision for cesarean delivery. It's a low transverse incision. And so it's been postulated that this low transverse incision that occurs when your uterus and cervix looks like this, what might happen during these second stage cesarean deliveries where, we've tried to have a trial of labor here, and a cesarean delivery it's not something that we've had a lot of time to talk about. So they actually, our potential for maybe not being as careful as usual in making that incision, we might have a higher propensity to have some extensions or some larger incisions than we expected during that second stage cesarean delivery incision, and that those incisions could extend into cervical tissue. And that injury into that internal cervical os could lead to this injury and trauma to the cervix, and then cause the cervix to become incapable of maintaining a subsequent pregnancy to term. I hope I described that well, because it's important. So it's really it's critical to understand that there's a distribution in the way people give birth, okay? And this is so fun to talk to people about, because it allows them to understand some of the questions around mode of delivery that really changes. It can dramatically change the way you would interpret study findings if you just understand this diagram. And so what this diagram is showing us at what stage of labor are first-time moms in Canada giving birth. So here you can see that there's pregnant people giving birth at all different stages of labor, okay? Deliveries can occur even before labor begins or during that first stage of labor, so prior to cervical dilation. And so you can see here in the green panel and in this yellow panel, 5% of deliveries in first-time moms are prior to labor even beginning. And then 15%, something has gone, something has indicated that delivery should happen before that second stage of labor even happens. So we shouldn't even try to have a trial of labor in these individuals. That's what's been decided. And so in first-time moms in Canada, we see that 5-15% split. So that's 20% of first-time moms that don't even have a trial of labor. Okay, and then there's that 80% that remain and progress into that second stage of labor. And so in that 80%, we see 2/3 have a spontaneous vaginal delivery. And you see that represented in this 55% here. These are all plus or minus, and they vary. They're, plus or minus 5%. They can vary by province, so they're not exact figures. So there's about 55% that will have a spontaneous vaginal delivery. But then there's that remaining third that will have something we collectively call an operative delivery. And so an operative delivery can mean you have that second stage cesarean delivery right away. Or it can mean that you try to use an instrument applied vaginally to facilitate a vaginal birth instead. And that looks like a forceps delivery or a vacuum delivery. And there's some pictures to illustrate what those are. I'm sure many of you have have heard or even had deliveries using these instruments. Now, what's important to remember about this paper and this body of work that I'm using this paper to represent is that, we talked about the increased risk of spontaneous preterm birth with second stage cesarean deliveries compared with vaginal deliveries. Okay. But when we look at this diagram, which vaginal deliveries should we be comparing these second stage cesarean deliveries with? Do you think that we should be comparing these second stage cesarean deliveries with these spontaneous vaginal deliveries? Do you think this should be in our comparison group? I would argue not. It wouldn't make sense for me to compare people for whom this spontaneous vaginal delivery outcome is not an option to, I don't think these two groups are exchangeable. And so this is not, my idea. This is something that you see these kind of erroneous comparisons happening in the literature, in the media, in conversation all the time. But it's well established in our world where we measure comparative outcomes, on a daily basis, that this comparison between a second stage cesarean delivery and any other vaginal delivery that occurs above this operative delivery line is inappropriate, because these people are not the same. Someone who has a second stage cesarean delivery cannot be compared to someone who has a spontaneous vaginal delivery, because they will never be that person. But whom you can compare them to appropriately in many cases are these operative vaginal deliveries. And so what we see in a lot of the previous literature is that all these vaginal deliveries get lumped together, the forceps deliveries, the vacuum deliveries, and the spontaneous vaginal deliveries, to compose our comparison group for second stage cesarean delivery. And that's problematic because the majority of those deliveries are inappropriate comparisons. And so for anyone who might not be as familiar with what forceps and vacuum are, I'll just quickly say that when there's an arrest in the descent of the fetal head during labor, and this all only happens when a woman is fully dilated, because an operative vaginal delivery using forceps or vacuum can't be used unless a woman is fully dilated. So when there is this arrest in descent, or when there's an engaged fetal head and something wrong happens where delivery has to happen quickly or expeditiously, then the option at this point, of having that spontaneous vaginal birth, is no longer available, and there's only these two options that remain. The first being that operative vaginal delivery, known as forceps or vacuum delivery. It can involve one, the other, or a combination of the two. And as I said, there are instruments that are used to extract that fetus vaginally. And the second option is that surgical option of the cesarean delivery. And it's also really important to note that if you go for option one, which can include, option 1A, option 1B, and that doesn't work, then you can either, if you've tried a vacuum delivery, you can try a forceps. And if that doesn't work, then you would have a cesarean delivery. And the same is true for forceps. You would never try a vacuum after a forceps, but you can go from a forceps delivery that did not achieve a vaginal birth, then you would ensue to a cesarean delivery. So that's kind of the relationship of these interventions and how they compare. And it's really quite important to think about the fact that we are restricting, if we're doing this properly, we should be restricting our comparison group to those forceps and vacuum deliveries, and not to spontaneous vaginal deliveries, because the use of those instruments means that you have a higher degree of injury to the cervix than you would in a spontaneous vaginal delivery. So you have these, additional risks to the cervix using these instruments because of this instrument-induced cervical laceration, which, these diagrams illustrate. So these would be lacerations of the external cervical os, not the internal cervical os. So the cervical os that's closer to the vagina and not the uterus. And so I've just actually, I had my lovely students create a graph for our presentation today. Excuse me. And they sent this to me this morning, and I felt so proud. Just a bar graph showing us the higher rates of these lacerations in inoperative vaginal deliveries compared to spontaneous vaginal deliveries. And they created a little forest plot for us, showing us that these operative vaginal deliveries have an over twofold higher risk of these cervical lacerations than spontaneous vaginal deliveries, just really hammering home the point that, especially for this question, we should not be looking at this group as a homogeneous group. We should be definitely parsing them out, because the risk of the injury, if our mechanism is because of cervical injury, that would be very different if we had this more distilled comparison group. And so I mentioned this, and I want us to talk more about this too, because the truth is the rate of cervical lacerations is low. Even we saw here, even in the inoperative vaginal deliveries, we're looking at rates less than 1%. And that's interesting. And the thing is, how do we know someone has a cervical laceration intrapartum? I mean, how do we know? We know if it's really bad, and we know if they have uncontrollable bleeding, if they have a hemorrhage, and that would be a telltale sign that something has happened, and then you would have a surgical repair. And so in my world, that would mean that I would be able to identify those people because they would have a diagnosis or an intervention code of having a hemorrhage or having a repair. But often these things can happen and we would never know. They would not be looked at, they wouldn't be ascertained, they wouldn't be detected, or they would be detected at different rates. And so I think our understanding of the rate of these injuries is probably really under-ascertained or underestimated. And I think we have to do a better job at looking at this for both the cesarean delivery injuries that are, are potentially affecting that internal cervical os, and the operative vaginal deliveries that are potentially affecting the internal cervical os. And I'm showing you this caricature of a map and asking, how does Canada compare with other countries with respect to trauma associated with operative vaginal delivery, so forceps and vacuum delivery? I want to talk about this because there's more than, obstetric trauma or maternal trauma of the pelvis and the pelvic organs during childbirth is a combination of different things, which include cervical lacerations, as well as high vaginal lacerations and lacerations of the perineum. And so I have a lot of studies that I do a lot of research focusing on the severe lacerations of the perineum that disrupt the anal sphincter complex and can lead to higher rates of fecal incontinence. And through that work, I've done a lot of kind of surveillance of these rates of trauma in Canada, and looked at what's been happening in other countries as well. And so it's important for this question, because I think if we're comparing modes of delivery in the second stage where an intervention is required, and we know that some of those interventions are associated with these injuries, and I know from my studies looking at a particular kind of injury that our rates of these injuries in Canada are very high, and that we're outliers compared to all other OECD countries, and have been for 10 years. On a global scale, we're outliers when it comes to rates of some of these obstetric injuries. It gives me pause, makes me question whether we should be really careful if we're considering something like, maybe we're going to be considering trying to decrease second stage cesarean deliveries by trying to increase forceps and vacuum deliveries. This is something that is often kind of recommended or discussed, that we make sure that in these deliveries that we use forceps and vacuum, that this isn't maybe the case for cervical lacerations as well. And I'm going to be devoting a big part of my research program over the next year or so to try to tease that out. And so I want to tell you what you're looking at in this graph, and I want to talk about it. So this is the rate of severe perinatal lacerations in 24 OECD countries that were reported in 2022 for the year of 2019, I think, or maybe 2021, for the year of 2019. And so what we see in the darker purple bars, what we see in the darker purple bars are the rates of these severe perineal lacerations, which I'm calling here OASI because another word for those lacerations is an obstetric anal sphincter injury. But for the purposes of our talk, let's just remember that there's severe lacerations between the vagina and the anus that involve that anal sphincter complex. So the rates of those injuries in spontaneous vaginal deliveries are in the darker purple bar. The rate in forceps and vacuum deliveries are in the lighter purple bar. And you can see that figure in the middle, that those two bars in the middle that are orange, those are the average rates in all OECD countries that contributed to this data set. And you can see my screen is extremely small at the moment, but I believe that says 1.4 and 5.3. And then you see Canada all the way on the right with the highest rates in both these categories of obstetric anal sphincter injury rates of 3.4 and 16.2. So, and I'll remind you that this is looking at, in the light purple bars, we're looking at these rates in forceps and vacuum deliveries. But when we separate those two out, and we should because they're completely different interventions and they really shouldn't be lumped together, what we see is that there's very high rates of these injuries with forceps and a pretty high rates of these injuries with vacuum. So you can ignore all of the bars here that say outlet, low, and mid. This is just corresponding to different levels of that of the fetal head in the birth canal, and just focus on these ones with the horizontal lines that say all. So this is looking at the rate of these injuries in forceps deliveries is if the reason why you're having an intervention is because your labor has been arrested, there's arrest in labor, there's not a problem with the fetus, it's just your labor is not progressing and there's maybe an obstruction or it's just not moving forward, your rate of having these severe perineal lacerations are over 20%. So 1 in 5 women are walking away with an injury that gives them a higher propensity of having fecal incontinence later in life. And in the same scenario with a vacuum delivery, we're seeing these rates that are just under 15%. Now, in the scenario where you're having an instrument, the reason why you are having an intervention is because there's an occasion of fetal distress or, a non-reassuring fetal status, then your rates of these injuries are higher. So you're closer to, 20, maybe 22% here with forceps and, over 15% with vacuum. So if we're seeing these really high rates with of these perineal injuries with operative vaginal delivery, we know it's higher in Canada than elsewhere. And we know, and I'll show you here in this graph, that it's actually increasing. So these rates of trauma in Canada are increasing, particularly with forceps, but also with vacuum to a lesser degree, and the combination of both. Then it gives me pause to think about, whether we should be really careful about knowing our rates of cervical laceration in those injuries before, and, have a proper comparison that is looking at these second stage cesarean deliveries against forceps and vacuum individually before we make some, inferences about some of the results that we were seeing with those higher rates of spontaneous preterm birth following deliveries with the second stage cesarean delivery compared to all vaginal deliveries. So I will just kind of take a break here and hear what everybody thinks about all this and just conclude that the associations that we see between mode of delivery and I guess and the role between mode of delivery and spontaneous preterm birth in a subsequent pregnancy and that role of cervical injury in that relationship hasn't been well enough studied to confirm a clinically relevant link. And that's where we are in the answer to the question that I posed in my title. And there's a thousand conversations we could talk around how we can study this, better, so that we can have a better idea. And I'll just kind of bait you and say that it's on the agenda, and it's something we're planning on doing better than has been done previously. So those are all the slides I want to share, and I look forward to chatting with you.
Thank you so much. This has been just absolutely fascinating. There's so much information. And we do have a question in the comments here. I'm going to bring it up so you can see. And this is kind of what I was wondering about too, whether, as someone who's given birth, how do you know whether you might be at an increased risk, and what could you do?
Well, so certainly if you have had a second stage cesarean delivery in a previous birth, and you have had an extension, that would certainly be a flag for me to say, I'm going to go and speak to my doctor about this, because extensions can happen. It depends on where, and our ability to again detect extensions and document them and record them so that we can look at them at a population level is limited, because we see rates all over the place. I think the mean is about 15%, but that can be kind of like upregulated or downregulated by a bunch of different factors. So if you've had a previous second stage cesarean delivery accompanied by an extension of your uterine incision, excuse me, I'm so sorry. Sorry about that. Then I would definitely bring it up in conversation with your physician if you're planning on having a second pregnancy. But I actually didn't have time to read through Brenna's comment, or question, so I'm just going to read it fully through if you just give me a moment. My second was a spontaneous return birth. Is there any way to see confirm if there's a cervical trauma? Oh, okay, interesting. Yes, my OB was not aware of these studies, and I was treated as low risk my entire pregnancy. And only through preemie conversations, discussion with her. Oh, this is so interesting. I'm so sorry that this was not brought. I mean, as I say, this was very recent, so I'm not sure when your second or your subsequent birth occurred, Brenna. It could be that this wasn't, or well, you found it yourself, so it must have been. Second, is there a duration that would reduce this risk, or is it too soon? So let me attack that one, because that's a really interesting question about, if we space out our deliveries, then could we minimize this? So in every model that looks at this relationship, you should be including the duration of the inter-pregnancy or inter-delivery interval in that equation, right? It's obvious, like completely obvious for anybody who speaks to any patient like you, Brenna, who, that's probably one of the first things you would consider. Many of the studies that have been done previously have not adjusted for this, and I'm sure they wanted to, but that's surely probably just poor study design, and they didn't have that data to include. And the answer is that there has been no one who has independently looked at this question with respect to inter-pregnancy or inter-delivery interval. So it's definitely something that we will have to work harder to get an answer for you. In general, and I'm sure you've heard this, we always recommend that you wait 18 months at least. But then it also, that interval depends on the age at which you delivered in that first birth, in the index birth, right? Because there are also all the consequences of just our sad body's devolution as well, which could factor into how long you might think, oh, if I wait 4 years, I might have not have the same kind of consequence if my cervix has had enough time to heal, and my scar isn't as fresh. But at the same time, then you're dealing with that extra 4 years of just like, our aging and cell death, just, something that I feel very, very strongly these days. So So that's how I'll respond to your interdelivery interval question. I think it's a good one, and we don't know the answer yet, but we have kind of the general compass of not earlier than 18 months is a good idea. How you would be able to know if you had a cervical laceration is tricky. If you had a severe cervical laceration, you should know. If you had an extension that was repaired, you should know. There are some ultrasound techniques that you can use where there's an ability to look at this with some ultrasound parameters. It's absolutely not standard of care, and I have no insight into any recommendation of, for example, some kind of urogynecologist that might be able to help look at that. And I should write that down because it's maybe something that I should talk to my clinical friends about making a pathway for. So I'm sorry I have probably very dissatisfying answers to both of your questions, Brenna, but thank you for them because they're both very important.
Well, and I think that's an interesting point right there about, listening to you share all this information makes me realize how far we've come in this last short amount of time, really, in terms of the questions we are asking now and the types of information that researchers like you are gathering and the questions that we're looking at going forward. I think the knowledge base around preterm birth and what might be causing it is so vast compared to what it was even just a few years ago. I know even in our case, the amount medicine had changed in 15 years meant the difference in myself and my boys being here. And to think of, what might happen in the next 5-10 years when you're able to start drilling down now that we've kind of got this first base layer of information, now you can drill down into these kind of questions like Brenna's asking, and that she's making you think of that, oh yeah, we need to know these details to get to the next stage. I'm wondering if maybe you can talk a little bit more just about where you see some of these kind of research fields going in the next couple of years.
Yeah, I want to, I want to really insert this agenda into, well, it's certainly dominating most of my work these days, but into a lot more of my colleagues' work as well. So I'm just hoping to see a lot more activity in this area because I think there is a lot of potential here. I may have made it sound as though this is not something worth looking at in these two groups because they both have these injuries, but I think that that's absolutely not true. I think that if we have better evidence through some of the studies that we plan on doing, and I'll tell you what those are going to look like, then and if we find out that these injuries are actually an independent risk factor for spontaneous preterm birth, well, just knowing that there's a pathway there is already incredibly satisfying just because it's so frustrating to not know. And I know myself just, personally and professionally that would be a great win. But then the other thing is if we do find out and we say these injuries are causing this, but there's no good option here, that's not the case because we can be more careful at doing these deliveries. If I showed you those rates of obstetric sphincter injuries, for example. There are countries that have half the rate of those injuries that we do. It's a possibility. And that goes for hysterotomy or cesarean delivery incisions as well. So you can minimize your rate of cesarean delivery extensions. There are places with lower rates, so we could put more quality improvement initiatives in place, and we could see results in, if we did see that was, we could see results in reducing spontaneous preterm birth if all those things lined up. And so to answer your question more specifically about where I see this field going is, I think, the next step here is to look really carefully, including models that, so my work includes like millions of deliveries. So in the next year, I'm planning to look at millions of deliveries and identifying populations of individuals who have two consecutive pregnancies, that had to have an intervention stage and had a subsequent pregnancy with a spontaneous preterm birth or didn't, and look at those factors in those people really carefully. And the nice thing about having millions of deliveries is these signals will show So if there are these links, we will see them. We will have enough births to see them. They may be subtle, but we know how to use data to tell us stories. And so we're going to be looking. I'm looking specifically at that. And so I'm going to be looking at this relationship between these deliveries very carefully, including all of the important factors such as what Brenna mentioned: inter-delivery interval, smoking, prior spontaneous preterm birth. All these things that I'm mentioning that to you and I seem really obvious haven't been done yet in some of these studies that are already, reporting on this. So just looking at that very carefully, and then even unpacking and scratching even further, digging down into what that role of injury is. So even if we did find that there was a link, let's say we looked at, and the thing is, we have to look at this really, really cleverly. Let's say we looked at a group of individuals who delivered with forceps delivery in a previous delivery, and the second stage cesarean delivery in a previous delivery. Okay, these are our two intervention groups, and we're comparing in their next delivery, taking into account all the factors that we can possibly measure. Then and that we have data for, of course, what their rate of spontaneous preterm birth would be. So, you would do this and you would have a sample size of, let's say, 500,000. So it'd be, that would be distributed in groups. And in that, you would say, okay, among these people, how many so even if you did find that, let's say we did find that there was a higher rate of spontaneous preterm birth in the individuals who had a previous second stage cesarean delivery. Does that tell us that having a previous second stage cesarean delivery is the cause or a causal factor? No, it doesn't tell us that. It tells us there's an association. And what that might be a cause of is it might be that whatever it was that caused that person to need a second stage cesarean delivery in their first birth might be a common cause of what caused the spontaneous preterm birth in the second birth. That might be it may have nothing to do with that second stage cesarean delivery. It could just be why she needed that cesarean delivery was why she had that spontaneous preterm birth. And we have to be careful about that when we talk about cesarean delivery in all studies, because often cesarean delivery is a treatment, right? Mm-hmm. It's a treatment for something that's not gone to plan in many cases. In second stage cesarean delivery, absolutely, because you're trying to have that vaginal delivery. It's not an intended treatment. It's an unintended treatment. And so you have this treatment, and so then you attribute all these bad things to that treatment when really it's not that treatment, it's why you needed that treatment. And the alternative treatment may have been worse. And so it's not, so that could be what we find. We could find that it wasn't about Brenna's subsequent second stage cesarean delivery at all. It was because of the reason why Brenna had that second stage cesarean delivery. But the other, so we'll be looking closely at that. There are ways to test for that using, statistics. And some of these, innovative models we have they're infer causality. And so the other thing we can do is we can look within that relationship and say, okay, so we have a higher risk of preterm birth in this group compared to this group. So how many of those in this group had an extension, or that would be a sign? We don't know that any of those extensions really did nick that internal cervical os. We don't know that for sure, but in that number of deliveries with that many data points, if you looked at within that group how many had an extension compared with didn't, just given the law of average and like the central limit theorem and statistics and the way, you would probably see within those groups, if there was a difference, you should be able to see it if you had enough data points. Because in general, probably you're going to get the worst outcomes in the people with the extensions if that's the biological mechanism. I hope I'm not going too far, but
no, I think it's really interesting, and I can see here that Brenna made one other comment about even just knowing that you may be at risk would be so helpful. I know that was our case with our boys. We have an older daughter, and we had some indication with her that we might end up in a NICU, and we knew for sure with our boys, because we had complications early on at 20 weeks, we knew we would end up in the NICU. And so we had that chance to prepare mentally as much as possible and to prepare physically as much as possible for the various outcomes. And even having that little bit of forewarning does make a huge difference when you're in that situation.
Absolutely. I can definitely relate. And I think that premise, that principle extends to so many things. Like if we there's just so much more information we could have antenatally that would help us prepare. Like, for example, knowing those rates of intervention I just showed you in the distribution of modes of delivery for first time moms in Canada. How many first time moms in Canada know that they have a 25% of having either an operative vaginal delivery or a second stage cesarean delivery? After, like, how many of them know that? Very few. Gave birth twice during my doctorate, and in both, I mean, not so much the second, but in the first, I was studying these rates like mad, of course, and even in my prenatal kind of in my education as the mom, when I took off my professional hat and put on my soon to be mom hat, I was trying to take in all the information I could, and no one ever told me about these rates. And I didn't internalize the fact that this could happen. And so when things don't go exactly as you think, you feel really, really sad, and like instead of rejoicing about this beautiful thing, your birth is actually feels like a failure. And so if we had more information to be able to say, listen, you're at high risk for this, let's talk about it. Let's talk about, what could happen, what it might look like, what the rates of this and that and this happening. It doesn't have to be that extensive for people who don't want to know, because there are some people who don't want to know. But I completely am on the same page, not only about this subject, but about several other subjects around labor and delivery. I think we leave women in the dark. We leave pregnant people in the dark. And I don't think it's because of ill will, but I think it's kind of a legacy of a paternalistic system where we infantilize pregnant people. That's a whole other Preemie Chats.
It is. I'm on board for that one too. But we should let you let your voice rest. And I thank you so much for taking the time to be with us and share this and start this part of the conversation.
I really, really appreciate it, and I had a great time, and I hope that your listeners enjoyed. I certainly did.
Thank you. And thank you all for taking part and joining in, and Brenna especially for sharing your thoughts in the comments. We appreciate that. And I'd also like to take the opportunity to thank the Canadian Premature Babies Foundation for having me host, and for AstraZeneca for their ongoing support of our educational programs. And a reminder that we are here at Preemie Chats every Friday at 1 o'clock Eastern Time. And if you want to go back and rewatch this presentation or any of the previous ones, you'll find them on our website. And I hope that you will come back next week for the discussion then. Until then, take care.